Andy and the rest of the task force for assembling this extraordinary group of doctors and inviting me to moderate. I'm truly honored to be here. My name is Dara Lee Lewis. I am a cardiologist at the Lown Group and also at Brigham and Women's Hospital and faculty at Harvard Medical School, where I teach the first-year cardiology course. And with my partner, Dr. Allison Kelly Hedgepeth, who you'll meet in a moment, we co-founded and co-direct the Women's Cardiology Program at the Lown Group. I've been a member of the Boston Club for a little over 5 years, and I have to say, I love everything that this stands for. And just this morning, seeing everybody on here is so exciting. And this panel is a perfect example of how we as professional women can use our expertise to lift each other up, empower, educate each other to live our best lives, and not just professionally, but also personally. So today we're going to talk about how we as women approaching or beyond midlife can keep ourselves strong and healthy. So I'm going to ask my panelists to introduce themselves, and then we'll dive into the questions that we as a group and the task force came up with. And then, as Carolyn said, we would welcome your questions in the last 15 minutes or so. So Nadine, will you kick us off, please?
Good morning, everyone, and thank you so much for this opportunity to speak with you and to interact with you today. I am Nadine Jackson McCleary. I am a medical oncologist at Dana-Farber Cancer Institute. I have been there since 2009 on faculty, and my clinical focus is the care of patients with gastrointestinal cancers. For those who don't know what that fully means, it's all the way from your esophagus all the way down to the anus and across the abdomen. So it includes the liver, the pancreas, the bile ducts, and of course the intestinal tract. I also focus on clinical informatics and do research in the care of older adults and those who are marginalized in terms of healthcare. Thank you so much for this opportunity.
Thank you, Nadine. Meryl, please.
Good morning. I'm Meryl LaBeouf. I'm an endocrinologist at Brigham and Women's Hospital. I'm also chief of the calcium and bone section in endocrinology and director of the skeletal health and osteoporosis and bone density unit, which I founded in 1987 after my fellowship. I'm also a professor at Harvard Medical School. My clinical interests are bone health across the lifespan, with a special interest in reducing fractures and in osteoporosis. And I do also carry out NIH-sponsored research related to vitamin D, falls, fractures, physical performance measures, and a new study on cocoflavanols, which is the highly concentrated catechins, epicatechins, flavanols in cocoa. So welcome, and I'm delighted to be here and join in this discussion this morning.
Thank you, Meryl. Allison.
Hi, good morning, everyone. I'm Allison Kelly Hedgepeth, and I'm a non-invasive cardiologist at the Lown Group, along with Dara. I will say that our office, located in Chestnut Hill, is quite special in that we really focus on the doctor-patient relationship. So I do have the luxury of spending a lot of time with each of my patients and getting to know them personally. And that's something that is of immense value to me as a physician. I am on staff at Brigham and Women's Hospital and also teach medical students at Harvard Medical School. And my clinical interests are in preventative cardiology and cardiometabolic disease. So it is great to be part of this discussion talking about disease in women and maybe with an air towards prevention this morning. So thank you for including me today. It's nice to see all of you.
Thank you, Allison. And Madeline.
Thank you for having dermatology as part of this wonderful meeting. I'm as excited to hear what the other physicians have to say as participating myself. I think that women in transition during the middle years, there's so much for us to think about, both in our personal health and the larger community health. I have been transitioning recently to a very managerial position in my practice. I own a private dermatology practice affiliated with Newton Wellesley Hospital and Partners Healthcare System. We have 7 dermatologists and a Mohs surgeon. We have an enormous amount of skin cancer And although from an oncology point of view, generally they're not as life-threatening, thankfully, as our oncologist on the panel sees, there's still a tremendous benefit to early diagnosis. And there's a lot of concerns about social media's portrayal still of tanning. Women who are under 50 are still dying way too much. Older folks, mostly men, but I think that there's a role to play in public health with continuing the fight against tanning. But thank you for having us here, have it all together, and I look forward to hearing what the panel has to say.
Thanks, Madeline. Actually, Madeline, let's start with you, because talking about tanning and healthy ways to do this, can you talk a little bit about the role of sunscreens and how you like to advise your patients to tan safely or to be out in the sun safely?
Yes. Certainly there is a huge range of what tanning means. Unfortunately, in the younger folks, tanning often means tanning beds. It often means going to the beach for 4 to 6 hours and getting a color. The color on the skin that the skin turns when you are tan is evidence of harm. 15 minutes in the sun per day on your arms alone gives the maximum vitamin D in a day that you're going to absorb. Vitamin D is also available, of course, in the supplements and in foods. So the idea of cosmetic tanning to make oneself turn a color is really what is fueling skin cancer, and particularly melanoma in younger women. There is no question that vitamin D is healthy. I personally have osteopenia and fell in my driveway 3 years ago and broke both my arms at the same time. I get it. And I don't go crazy with my older patients particularly. I tell them, do not stay inside. When people say, oh, I don't have to worry about sunscreen, I never go out. I'm like, that's wrong. You need to go out. But if you've had precancerous and cancerous lesions on your face, wear a hat, get some sun on your arms. We do have patients who develop precancerous and cancerous lesions, in the tens per year. Those patients have to be treated differently. But I do talk with all of my patients about vitamin D and that is important, because we don't want everybody falling and breaking both arms at the same time.
Great, thank you. And I know that you have an interest in different types of sunscreens if we are outside, the chemical versus the physical blocks. Can you just say a quick word about that?
Absolutely. First of all, we also are in a wonderful place where many mainstream stores are selling sun protective clothing. If you are at the beach, you should not be at the beach without like a long sleeve sun protective shirt to throw on if you're walking down the beach. There's no reason to smother yourself in a cream that contains all sorts of things, including preservatives, when something so simple and inexpensive and reusable can do. But of the sunscreens, there is no question that there's a lot of attention on a lot of the chemicals in sunscreen, as well there should be. Zinc and titanium are no doubt the absolute best ingredients for sunscreen. They work by reflecting sun instead of absorbing it into the skin and changing it into another form of energy. They've been tested ad nauseum, nanoparticles, etc. They are all safe in the zinc and titanium. If you cannot pronounce the ingredients in your sunscreen, you should get another sunscreen. So sun protective clothing and zinc and titanium sunscreens, which are now pretty widely available also even at the pharmacies. They used to be harder to get, but now they're stocking the shelves.
Thank you. And those are the ones that turn your face white, right?
Not anymore. Not anymore. They figured it out.
This whole vitamin D question and the osteopenia brings us to Meryl. And Meryl, I wonder if you could comment on how we can be proactive and try to prevent the development of osteopenia and osteoporosis beyond vitamin D.
Yes. So bone health is extremely important. 1 out of 2 women 50 years and older will develop an osteoporotic fracture in their remaining lifetime. The risk of a fracture, each year there are 2.3 million fractures each year, is greater than the risk of a new heart attack, breast cancer, or prostate cancer combined. Yet there's currently under treatment of osteoporosis, particularly in patients who have a fracture. So if you've had a wrist fracture, or if you've had a hip fracture, or if you've had a femur fracture or spine fracture, or possibly a pelvic fracture, you are at markedly increased risk for other fractures, and only 20% of patients after a fracture are being evaluated and treated for osteoporosis. Prevention is really important, and in terms of weight-bearing exercises that do not incur flexion or bending of your back are important. So keeping your back straight is important to decrease the risk of spine fractures with exercise. And exercise is important. Healthy nutrition, calcium. Postmenopausal women need 1,200 milligrams of calcium a day. Men 70 and older need 1,200 milligrams of calcium a day from diet and supplement. And we recommend for women with low bone mass or osteoporosis, 800 to 1,000 units. 1,000 units of vitamin D is safe. The story of vitamin D and bones are evolving, and I'm working on a NIH grant, and we're submitting a publication right now on the effects of 2,000 units of vitamin D with or without fish oil compared with placebo, double placebo in 25,871 adults from 50 states. And you may hear about the fracture data, but we just presented some data that was published that showed that 2,000 units of vitamin D in an ancillary study to the Joanne Manson's vitamin D and omega-3 fatty acids study actually did not increase bone density more than the baseline level, which was somewhat surprising, but it was observed in our study and in another study. So how much vitamin D is important? That more vitamin D is not necessarily better, and in fact high doses of vitamin D have been shown to cause bone loss and some harm in a study from Canada. So I think it's a modest amount of vitamin D. 1,000 units is safe. Some people need more because they may have malabsorption or they may have some alteration in their gastrointestinal absorption. But the predominant source of vitamin D is through photoactivation in your skin. And as we in areas where there's covering of the skin, yes, there can be D deficiency. But currently, we like the vitamin D level surprisingly around 30 to 40 nanograms. Around 30 nanograms per ml is actually the sweet spot because it's a U-shaped curve in terms of vitamin D. We think too little is bad and too much is also bad, and there's the U in the middle. That's the amount that's probably good for bone, and you're going to hear more about this over time.
So Meryl, do you check vitamin D levels? I check it in almost all my patients, at least as one baseline, because how do you know how to dose if you haven't had a level?
Yeah, now I check vitamin D because I see patients who come to me for some concern about their bones, low bone mass, osteoporosis. I will tell you that in our studies even in Boston, the level of vitamin D was pretty good, and about 40% of the participants in these studies were taking supplemental vitamin D. I think it's, I think that there's no harm in checking a vitamin D level, but I will tell you in terms of the medical society, the U.S. The U.S. One big organization,
the Preventive Task Force, I think.
U.S. Preventative Services Task Force actually recommended against checking vitamin D. So there are some evolving discussions here to get at what would be the I think the best level of vitamin D for bone health, and we don't have all the answers yet. We don't. Joanne Manson published her paper in New England Journal related to vitamin D in cancers and cardiovascular disease. There were some evidence of some subgroup benefits. This is being studied further, but I think that right now a vitamin D level of about 30 nanograms, 30 to 40 nanograms is safe and is reasonable, and going to high levels, as some patients may be taking 4,000 or 5,000 units a day, is not a good idea. So it's a matter of moderation, but in general, you're going to learn a little bit more about vitamin D, at least in bone. But there are other studies, ancillary studies, that are looking at in the general healthy population to be distinguished from patients who may have, like that Nadine may see with malabsorption or gastrointestinal problems. They need a lot more vitamin D. But patients who in the general healthy population, so may not need as much vitamin D as being presented to them.
Sure. Okay. Thank you. And I know that some of these trials are making an extra effort to include women with darker skin because there's a whole issue about absorption of vitamin D if you have darker skin. That's true of the VITAL study, I understand.
Yeah, and I think this is a really good point. I'm really proud to say that in the VITAL study, and this is 25,871 participants, men and women, enrolled from 50 states. 20% of the participants were Black African Americans from across the country, and these participants were enrolled nationwide. Yeah.
Great, thank you. All right, well, let's shift gears a little bit because Nadine, I want to make sure we talk about some of the new screening guidelines. And can you talk in particular about colorectal screening guidelines and how that's changed over time?
Sure, I'll just add a little bit to the vitamin D conversation, and that is also an emerging field for colorectal cancer, in particular other cancers as well, such as breast cancer. And the data has been a bit conflicting in that there was a recent study by one of my colleagues, Kimmy Eng, showing that younger patients taking vitamin D at 300 IUs had some cancer prevention of early occurrence of young onset below the age of 40. But for those patients who are 50 or above, those are the patients that I tend to see, actually patients in their 80s, the data is still kind of unclear and conflicting. So I look forward to all the data that Meryl and colleagues are providing because it's really an exciting area. And I would nod to it's cheap. Vitamin D is very inexpensive. And so there's some data as well that adding vitamin D to the chemotherapies we give for colorectal cancer is beneficial for preventing recurrence. In terms of screening, this has been a topic that's media often. I think it's in cycles. Colorectal cancer screening, if it were provided to the population, is said to account for about 60% of the cancer that we see for colorectal cancer. Of all the cancers that I treat, it's the one of two cancers that can be screened for. The other is anal cancer in certain populations, but not all. And I'll include rectal cancer here as well, because you're really looking at the rectum and the colon all the way up to just before the small bowel. So you get a very good look. The challenge with screening, as many of us know, it's not the ideal test. It's somewhat invasive and logistically challenging. Most patients dread the prep. So drinking that mixture to kind of clear the gut. And for some folks, they have a lot of gut to clear in terms of what their diet has been previously. Many gastroenterologists will even recommend going on a clear liquid diet for a day or two before you start the prep. And for those of us who like to eat and have a good snack or something before bed, that's about 3 days of your life that you're doing it. Colorectal cancer screening with colonoscopy is the way that we usually think about screening, but there are many ways to do screening. And so there's some attention being paid to, is colonoscopy, because it's not achievable for everyone right away, is it the right kind of first step? You can do tests for fecal occult testing. There's Colo Guard now. So there's some non-invasive options. And I mentioned them because particularly in low resource settings or populations who are reticent to do the full colonoscopy, this still provides an advantage for those populations for us to be able to detect colon or rectal cancer earlier than we otherwise would. So incredibly important. My favorite study is done in Delaware, in the state of Delaware, where they said, you know what? We're behind. We need to improve. We have far too many patients dying of potentially curable cancer and being cancer detected at late stages, particularly amongst Black patients. So we're going to mandate and we're going to put the onus on the healthcare system and the payers. So they enforce that the payers would cover screening universally across Delaware. What they found was kind of that every patient who had access to this, not just those patients they were targeting, which are Black patients in that study, but also Caucasian patients, other races and ethnicities, had an improvement in screening. And once cancer was diagnosed or detected, it was detected in earlier and potentially curable stages. So it made a significant difference. So that number of 60% when we do screening in terms of reducing the risk of colorectal cancer, that being the proportion that could be reduced is pretty remarkable. In terms of the age of screening, we think about starting at age 50. A lot of us have challenges with starting at age 50. At 50, a lot of things are happening kind of simultaneously. And particularly when we think about us as women, being kind of sandwiched between taking care of younger children, but also taking care of older parents or potentially partners, this becomes really a challenging age to think about yourself. Fortunately, based on some of the rising incidence of cancer in early ages, we dropped the screening age to age 45. And so that is not fully supported by all payers, but many are coming on board. And the goal there is to be able to pick up on this, again, curable cancer, can't emphasize that enough, earlier, before it becomes a problem, before it's metastatic, before it's incurable.
And importantly, before anyone has symptoms, right? You could feel totally fine and be harboring something.
Well, that's a great point, Dara. I would say probably 40%, 50% of the folks that I see come in saying, I felt perfectly fine. I didn't know anything was happening. And that's happening even in patients with advanced disease. That may be, I'm so busy, I can't pay attention to all the cues my body's given me. But honestly, there are folks who just don't feel unwell and feel that I can't possibly have cancer because I'm doing well, because I'm active, because I've been quote unquote healthy all my life. The fact is we're all susceptible, and this is just something that we're fortunate enough to have an opportunity to do screening for. So we should take advantage of it and make it easier for all of us to participate in.
Do those screening guidelines change if you have a family history of colon cancer?
Right. So if you have a family history of colon cancer, and that is somewhat problematic, we used to screen for genetic risk or hereditary predisposition to colorectal cancer based on your family history. Well, how many of us know what Uncle Bob was diagnosed with or cousin Sharon had? Most of us don't really know all the details of our family history. So it was a little bit presumptuous if family history kind of questions alone would pick up on this risk. And in fact, many studies have borne that out, that we miss a number of patients who do have a genetic predisposition. If you have a family member, however, who has been diagnosed, the general guidelines is to start screening 10 years younger than when they were diagnosed. So my father was diagnosed with colorectal cancer at age 56, just as I ended my residency and starting my fellowship in oncology, which is why I'm a GI oncologist. And so I'm supposed to start screening at 46. Now the age is 45. So I tell my patients the youngest of those two, whichever one comes first, start your screening. And then there's a fortunately smaller population who have a germline or something they were born with, genetic predisposition, things like familial adenomatous polyposis or Lynch syndrome. These are conditions in which you may be born with a risk of colorectal and other cancers. And those patients have stricter screening guidelines, not only for colorectal cancer, but for other cancers as well, and really should be managed by one of the top-notch centers that we have at our disposal. So a high-risk genetics clinic or a Dana-Farber or Lynch syndrome clinic.
Perfect. And then for very low-risk patients who don't have any known history of colon cancer in the family and maybe have never had a polyp themselves, what do you think of that? The Colo Guard, people may have seen this. It's a non-invasive where you just take a little bit of stool and send it in. And if it's normal, it doesn't detect the DNA from the cancer, you can go another 3 years without a screen, and it doesn't involve an actual colonoscopy prep in any way.
Yeah, so I think there's a lot to be said for providing additional modalities for screening. So the more options that we have to be able to pick up on and detect a cancer before there's a challenge, I think we should take advantage of. So absolutely behind Colo Guard, many of my GI colleagues also support it, but they will also call out that these studies are done in unique populations, pretty homogeneous populations, and we do need to pay attention to whether or not the findings are truly generalizable. And so if you're seeing a patient or you have a friend who does not fit in kind of the population that was studied, typically Caucasian patients, then you want to think, is this still going to be enough? So pay attention to your body. I would say keep that in mind when you think about your screening, but certainly take advantage of any and all opportunities you have to complete screening in a timely manner.
Thank you. Thank you. Perfect. Allison, let's switch to you. And speaking about screening and trying to pick up disease before it's present, I know this has been a real passion of yours, having worked in a place where people come to you in the late stages of disease, you've shifted to try to detect women when they're still healthy before they get to the emergency room with the big heart attack. Can you talk a little bit about the major issues as a cardiologist that you emphasize to your patients in terms of prevention?
Yes, absolutely. So, I think so much of the prevention, right, is just understanding not only the population risk, but my personal risk early. And I think there is sometimes the disconnect in why people are frustrated, right, and maybe don't fully buy into this kind of hunting for things that could be wrong right before something is actually wrong. So let me just, maybe take a step backwards and just kind of, restate the cardiovascular landscape, because I do think that's also a misconception. I think the message that cardiovascular disease kills men is still heard loud and clear. And unfortunately, the data is, ladies, by the time we're in our late 60s, the prevalence rate equals men. And in our 70s, guess what? It exceeds that. So this is, very important to women of all ages, but particularly as we age. And most cardiovascular disease is modifiable, right? We can prevent having an event. An event is usually a heart attack or stroke. So the bulk of cardiovascular disease that we're talking about is atherosclerosis, which is the buildup of those cholesterol plaques in our artery. And it's not until those plaques block 70% of blood flow that patients start having symptoms. So that's really advanced, disease before you are aware of it, right? But this disease buildup usually takes decades. So, the good news is if we understand your individual risk, we really have time on our side to modify the trajectory, which is important. So some of the misconceptions I hear from people frequently are kind of that mindset of, if it's not broke, I don't want to fix it. And kind of paired with that is, I don't want to be on medications. And, I also share those sentiments. I certainly don't want to take medications myself as a patient, as well. The problem with that mentality is we really need to have our scientific hats on. And the beauty of science is that you're willing to reevaluate your beliefs, right, and change your actions based on what the data is telling you. So if individual risk is really there, then we really need to go after what those risk factors are, because we have, potential decades to change that trajectory. The other misconception I hear all the time is that I don't want to live, till I'm 90. And I think what people are saying, what they mean when they say that is, I don't want to give up my quality of life. I don't want to give up my ability to engage in the world the way that I want to do. I don't want to be in and out of the hospital. I don't want to lose my independence, right? So the cool thing is, when we're talking about cardiovascular risk, prevention, we're not only talking about expanding your lifespan, but we're talking about expanding your health span, right? So if we can put off these chronic diseases, the diagnosis, and we can push it from your 60s to your 70s or to your 80s, right? You really are giving yourself the gift of decades of doing what you want to do and how you want to do it, before things go wrong. Once we have a chronic disease, then obviously there's things we can do, a lot we can do to modify it, but it's always better to be on that preventative side. So traditionally, how we've approached the prevention is really screening, right, for elevated cholesterol, elevated blood pressure, and the presence of diabetes. Certainly, there needs to be really a nuanced discussion between each of you and your doctor regarding, what your family history is. Are you seeing any of these? Can any of these be controlled with lifestyle alone? Because the sooner we see little abnormalities, right, in these kind of general health principles, the easier it is to address with lifestyle only, with a goal to really reverse the process and understand the root cause. If we wait sometimes until things have been going wrong for decades, then it's harder to control with lifestyle alone, but not always. And I will see keeping an open mind about using medications when the risk benefit really benefits you is really important when we're talking about prevention, right? Because I have many patients that I have on the right medications for them, and they haven't had an event, right? So we're using it for prevention. And what's the goal, right? To get to 90 and they say, doc, nothing happened. I haven't been in the hospital, right? I mean, so there really is potential for a lot of, gain in your quality of life and your independence, with this mindset on. Another disconnect that I see, and then I'll let Dara take the floor back over, is that sometimes we don't fully understand what our individual risk is. So in women in general, I think hypertension sometimes goes missed and is attributed to white coat blood pressure elevations. And then, they end up in our office and we do an echocardiogram. And when I'm looking at their heart, I see this big hypertrophied, thickened heart muscle, right? So the same as this bicep lifting weights for years, right? I see this heart muscle that's pumping against high blood pressure. So there are women that have white coat hypertension and they have a normal echo and their blood pressure really just goes up occasionally with anxiety, right? And then there's women that have real hypertension, right? That it's been attributed to just that anxiety, right? And so diving in deeper to really understand your personal risk and making sure you really know which camp you're in is important. And the earlier you do that, right, the easier it is to kind of change that trajectory.
Perfect. That's great. How would you say the role of stress in leading to heart health is? I'm just looking at some of these amazing questions and we're going to get, I think, to most of them, but how much is our work stress affecting women's heart health over the years?
So it affects, stress affects women a lot, right? And part of that is kind of the same message that Nadine said, that we are sometimes willing to ignore our own symptoms because we have other things that, we view as more important, right? And it's easy to honestly let years pass. I think we all know that, right? Oh, I've been meaning to go in and get those labs done. And you're like, oh gosh, that was 2019. I was thinking about that, right? And here we are in 2021. So I think there's that element. But then there's also the element of kind of that stress phenotype that we know you have elevated cortisol, right? And these kind of stress response. And guess what? There's no lab test to do for that, right? That is, really just, those women tend to be sleep deprived. Sometimes we see changes in their insulin sensitivity and are more likely to be on the diabetes spectrum or were diagnosed with diabetes earlier. So I think there's a lot of ways that stress can actually cause, real cardiovascular risk factors, right? And then there's this other element of the lifestyle piece where I don't have time to exercise, I don't have time, to sleep right, and that self-care element too, that, if that happens for a few weeks, right, we all have the reserve, right? But when it happens for decades on decades, right, that's where we really see that as part of the disease process itself.
Yeah, no, I think that's so important. The pillars of health that we always talk about in heart health, which I think are relevant for all of you in every organ of our body, but sleep, nutrition, stress management, and exercise, and anything that throws that four-legged stool off of balance is going to affect all the others. And it's going to affect not just our heart health, but really everything. Which brings me to this amazing question in here. This is a wonderful question saying, what advice would you have for young adult women like my daughter with respect to how should she prepare now to become a healthy 50-year-old to avoid these preventable health issues, including cancer? So I'm going to let each of you just take a moment to say, what advice would you have for a young, healthy person who wants to stay healthy? And Madeline, maybe you'll start with that.
I think that balance that we were talking about before, outdoors, great, get your exercise outdoors, protect when you can, don't tan for cosmetic purposes, protect yourself if you're running, and watch your skin. If you see something changing, don't say, oh, it's probably nothing, and then ignore it. We see women under 50 all the time with really dangerous skin cancers that could have been caught at an earlier stage, just like colorectal cancer. The difference of 1 millimeter of depth, which is a tiny, tiny amount of melanoma, can make the difference between metastatic melanoma and completely cured melanoma. even though there's better treatments now for advanced melanoma, it's the kind of cancer that gives cancer a bad name. So just women should be looking at their bodies. They should be aware of the changes. Like you were saying, if you don't feel good, don't just write it off. I'm not feeling good, or I'm under a lot of stress. Go to the doctor early, get things checked out, do one's, self-assessment. I always tell women, if they're going to do their breast exam, which of course most don't do, but look at your skin at the same time, and just be aware and put those things in your calendar. You put things in the calendar of the kids, back to school meeting, but you don't put in the calendar, I'm going to do a self-breast exam and look at my skin. So I think getting that awareness scheduled on your calendar is the best thing to do.
What do you think about an annual skin check for people who may have had childhood sunburns or a family history of melanoma?
Absolutely. And I know that one of the questions that you sent out to the panelists was sort of difference in socioeconomic class and how that affects medical visits. So certainly people who do have co-pays and things like that, they often don't want to come for a yearly exam, have to pay a copay, particularly if they have a high deductible plan. But it is, if you have a parent with skin cancer, or you have many moles, or live alone and can't see your own back, absolutely, it's a wonderful way. Medicare, unfortunately, decided not to reimburse physicians for full skin checks during a primary care exam, for example. So if you go for your annual, regular blood pressure check, et cetera, your doctor is not going to look at your skin. So if you have any of those additional risk factors, seeing a board certified dermatologist once a year is a wonderful way of getting ahead of it. And certainly it's a very easy thing to biopsy a slightly suspicious tiny mole, very, very easy and life-saving potentially.
Thank you. I'm sure with COVID, this wasn't so easy for people to get a skin check.
And we saw a tremendous amount of skin cancers when things started coming back again.
Wow. And Nadine, actually, let's go to you next with this question about COVID, and also this question about how can we stay a healthy young person as we become a healthy older person, not just for colorectal cancer, but cancers in general. Any advice for us?
Yeah, I think absolutely agree with Madeline in terms of prioritizing your health. Knowing what's normal is important. Sometimes we don't recognize that something a habit, a pattern that we have in terms of our lifestyle or behavior since childhood is actually not normal and not healthy. One example, thinking about GI cancers particularly, is bowel movements. I often ask my patients, well, how often do you have a bowel movement, and do you consider that normal for you? And the answers that you get back are surprising. Some folks would say, once a week is normal. And, I shouldn't expect more than that. It's not. And so having a conversation about those things that seem kind of taboo is important. I would also recommend having a health accountability partner, particularly as women. And that may not be the person that lives in our home with us or a family member. It may be a friend, a college buddy. You just check in with each other. Have you done this? Have you done that? That requires being vocal about your health with someone. It doesn't have to be everyone. You don't have to post it on Facebook or Instagram or whatever social media app du jour, but you can certainly discuss it with someone. So I have friends that we check in about our mammograms. We check in about our colonoscopies. We encourage each other and coach each other through those things. And then we remind each other, did you follow through? Because the reality is, no matter what age we are, we all have folks who have been through a lot in terms of their health, and we can learn and teach and share so we can improve the health of others. I would also recommend recognizing what balance looks like in your life and developing a system of well-being. And it's not going to be every day that I'm perfectly balanced. Schedule yesterday was insane. It's just, I can't even talk about it because it just doesn't make sense that I'm still in a meeting at 10 p.m. and putting 3 kids to bed, but I was. But today is a day where I say, some meetings are going to be canceled. This is where I kind of need to reset myself so I could be prepared for the next day that may be a bit more stressful. So balancing over time and recognizing the ways that you can do that. And then the last thing I would say is figure out how to navigate the healthcare system. We as women, there's a question about gender imbalance in colorectal cancer and cancer in general. Yeah, there's gender imbalance in everything, and women tend to get the short end of the stick. Women do tend to get diagnosed with the more aggressive right-sided colon cancers that have more space to grow and have a different biology and behavior pattern. But part of that is the logistics around navigating the healthcare system. So if you know that something's abnormal, you've done your due diligence, you've advocated for yourself, and you get this response that, yeah, I'll see you in a month or two, right? Delay is not denial. And just because someone says, I really don't have time to see you, you want to call back and be persistent, and I think politely so, but you can still say, can you add me to the wait list? You know, I'm really concerned about this. Make it personal. People get that, but figure out how to navigate the health system and develop trust with your care team, your physician, your advanced level practitioner, to make sure that they know that they can reach out to you and you can reach out to them if there's a need. And hopefully that you have some flexibility in ways that you can reach out to them.
Nadine, that's such good advice. And it is so, every day I see examples of how broken our healthcare system is. And you hate to have to tell people that they need to be an advocate for themselves, but they do, don't they? Because people who don't push get to we'll see, you have blood in your stool, we'll see in 6 months, where that could be something reversible, treatable, curable now, and 6 months from now, it may not be. And people are like, oh, okay.
I've had, and this happened even this morning, a patient paged me, it was an emergency, and then apologized for paging me. I'm sorry to bother you. And it's insane to me that I have to keep reminding patients that this is actually what I do and I enjoy doing it and I'm passionate about it. It's not a bother, this is my job. And what bothers me more is if you're in the hospital or have some unintended consequence because you couldn't reach me or someone else that you needed. So I do share my cell phone number with patients. I make sure that they know that they can reach me if they need to, just because to help to reduce the impact of illness, particularly in the setting of cancer, I think is incredibly important.
Which is amazing, but then your balance goes out the window, doesn't it?
Well, my balance goes back in the window. The way I look at it, the less patients I have to see on the inpatient service during a busy clinic day, the better it is for me. And so knowing that I can connect them with the nurses in the office who appropriately triage, that they are being tended to, that I don't have to worry about them, that there's not some delay in their cancer treatment, for example, that throws my schedule off, the better overall. So that for me works. I think everyone has to find what works best for them.
Thank you. Meryl, can you address the question that started this conversation about how to keep a young, healthy woman young and healthy, or older and healthy, and specifically also the role of calcium supplements versus calcium in the diet has come up in the chat?
Sure. Well, osteoporosis is a silent disease, and so it's important to understand one's bone health and to try to prevent bone loss over time. Because peak bone mass is achieved in the 20s, and then after 40s, there's some bone loss over time, particularly with women in the time of menopause. And in terms of calcium, 99% of your calcium's in bone, so it's important to have a good dietary calcium, and if you can't achieve a good dietary calcium, and in women 51 and over, it's 1,200 milligrams a day. Below that, it's 1,000 milligrams a day. But it's better to take calcium from diet. 70% of the sources of calcium are from dairy, but there's a lot of calcium supplemented soy milk and other calcium supplemented nutritional preparations. But if not, we recommend a calcium supplement. But it's preferable to take calcium from diet. And then in terms of diagnostics, bone densitometry is widely available, and it can detect low bone mass and osteoporosis. It's recommended for younger patients who have risk factors, and there's a huge list of risk factors for osteoporosis. It could be related to cancer therapies, it can be related to hyperthyroidism, it can be related to too much hyperparathyroidism, also gastrointestinal disorders, many drugs, and steroids, glucocorticoids for asthma. So there's a big list of risk factors, and for young women, loss of menses, too much exercise, anorexia. So it's important to identify causes of low bone mass and reverse it, because if a patient has celiac disease or sprue, then putting them on a gluten-free diet has been shown to increase bone mass. So we look for prevention, for reversible causes of secondary causes of low bone mass, and And also, bone densitometry is routinely recommended for and covered by Medicare for women 65 and older, all women regardless of risk factors, and then 70 and older. So that can help in terms of identifying somebody with low bone mass, because fractures increase exponentially with age, and a fracture is a sign of osteoporosis. So a wrist fracture is a sign of can be a sign of osteoporosis also. And so it's important to talk to your doctor about treatment or evaluation and treatment. Those two go hand in hand.
Thank you. And for people who don't eat dairy, what about the plant sources of calcium? Are those as bioaccessible, bioavailable?
Yeah, there are a lot of, there's calcium in tofu. There's calcium in supplemented to like soy milk or almond milk. That is a supplement, but it's a dietary source of calcium. For patients who take a certain calcium preparation, carbonate, it's better to take it with food because they can absorb it better, whereas calcium citrate's absorbed on an empty stomach, and it is actually better absorbed. So, I think it's best if you can take calcium from food, and the National Osteoporosis Foundation, now called the Bone Health and Osteoporosis Foundation. I've served on the board for the last 12 years, and we just have a clinician guide that's in press. But they have on their website and calcium content of various foods. It's relatively easy to look online and get the calcium content of foods to see how to adjust your diet. To really make sure you have a good amount of calcium in your diet, and not too much.
Thank you. Okay, perfect. And speaking of diet and prevention, maybe Allison, I saw you addressed a question in the chat. Thank you, about the healthiest diet to prevent heart disease. And Nadine, I'm going to ask you to quickly comment on diet to prevent cancer as well. But Allison, can you weigh in on that as well?
Yeah, so the best diet data that we have for diet is a Mediterranean-like diet with a real emphasis on unprocessed food, right? So if the label has, things that you don't recognize on it, that is not real food. And if you kind of base your meal prep with that mantra, that really helps make it simpler, right? Because obviously in an ideal world, all of our meals would really be coming from the produce department with some healthy protein in there as well, and limiting the processed things that we as a society really gravitate to, because we all are juggling so many balls in the air that we really sometimes don't have, the time carved out for meal prep. I want to say a couple other words, and I'll be quick because I know the hour is getting is drawing near. But for prevention for women as we age, I just want to highlight the data that we have on exercise, because this is something that really gets brushed over, and I have really good mortality data, right? You will live longer if you exercise regularly. And that can take the form of many different things depending where you are on the spectrum. But if you are a person that is a couch potato, if you start doing something regularly, we see a mortality benefit. If you have moderate exercise ability already and you commit to that and increase it, we see a similar benefit in you. So there really, across the spectrum, is potential benefit from just doing it regularly and kind of addressing it as we think about healthy habits, right? What we can do and how we can do it on a regular basis. The other screening tool that I just want to say 2 words about is a coronary artery calcium score. So this is a low radiation CT. So the dosing is similar to a chest X-ray, so super safe test, and it's been around for decades. But it's just in the past couple years that insurance companies are paying for it, and it's actually on the screening guidelines. So we use blood pressure and cholesterol to kind of figure out who's low risk, who's medium risk, who's high risk for a cardiac event. If you're in that gray area where we're not sure, this test is probably the best test for us to identify subclinical disease. So it's just looking calcific disease in our coronary arteries, which are the arteries that feed the heart muscle. So as atherosclerosis, that cholesterol buildup progressive, your body kind of walls it off and it becomes calcified. So if we see evidence of that process on the calcium score, you're somebody that we should probably really dive in deep with your risk factors and potentially be more aggressive with. Likewise, if you're older in age, where we're really expecting to find some evidence of this and your score is 0, right? Then that also is a nuanced conversation with your doctors about what is my real risk? What is the role of medications? And I find it very humbling in going from population science, where we kind of apply, these guidelines and try not to miss everything, to then looking at people's individual risks, because I have to say, sometimes it's surprising what we find in people that we don't expect to have a high calcium score, right? And it's because we're still not sophisticated in our way to really understand family history and risk there. Sometimes we really find disease that if we know about it early, we would make a treatment plan different than otherwise we would do at that age group. So I'll leave that. For
example, yeah, no, and you might start a statin medication to lower cholesterol in someone who otherwise might seem healthy, but has a lot of calcium in their coronaries.
Yeah, absolutely. And, the statin is, could be an hour-long discussion in and of itself. And I think there is a lot of concern from the general population about this class of medications in general. And I will say, of all the things that we have for prevention in cardiology, right, for a high-risk person that it's taken decades for that degree of atherosclerosis to develop, we can stabilize things, right, with a statin in a matter of months. So for the right patient, those are really remarkable medications, right? But you have to kind of have a nuanced discussion with your physician to really outline the clear risk-benefit evaluation.
Great. And just to address a question that had popped up in the chat, the goal is not to reverse the calcium or the atherosclerosis, which really is not reversible, but it's to stabilize it. So the word you use, stabilize, and prevent it from turning into a problem. So some people live with calcium in their arteries for a good long life, never having a symptom, never having a heart attack. And as long as we can stabilize it, that would be the goal. And then quickly, Allison, can you comment on how much exercise is the right amount?
Yes, and I will say that the soft plaque, right, which is the vulnerable plaque that we're worrying about rupturing and causing an acute heart attack, that doesn't show up on the calcium scan. So again, there's some nuances to that discussion that you want to make sure you tease out with your own physician, right? But the goal is to have it become calcified and stable. But if we do see evidence, we know that that process has started in you, and that opens the dialogue about being more aggressive with medications and risk.
Thank you.
The amount of exercise that we have data is 150 minutes a week of moderate activity. So that could be walking 5 days a week for 30 minutes a time, right? That could be doing, every other day, something that, is a little longer in duration, but it's not a big number. It's a very doable number. And we really do see those mortality curves diverge. So I think it's really important to think about, how can I make this part of my, regular regimen?
Perfect. And then I'm going to ask each of you to give a little summary of sort of words of wisdom, closing comments, take home points. And Nadine, I'm going to start with you and also ask you to add on to that the question of diet and cancer prevention.
So first of all, thank you, everyone. I've definitely benefited from joining you all today. I would just add to everything that Allison mentioned about diet and just say ditto for colorectal cancer, GI cancers in general, just for your overall health. Much of what we spoke about are the basics of advocating for yourself, knowing your body, but trusting your body, making time for yourself. These are not things we were taught in medical school. These are just general life lessons, but they definitely apply for guarding your health. The other thing that I would say is, making sure that we think about not only prevention of cancer. Our goal is always prevention, but there are 2 levels to prevention, and in my case, multiple levels. There's primary prevention, so not getting the disease in the first place, but there's still a value to secondary prevention. So even if you or others have been diagnosed, it's still worthwhile to put these practices into place to reduce the risk of a condition worsening or recurring. So thank you again for your time.
Thank you, Nadine. Madeline, can you give us some closing words? Oops.
Yes. I think I said plenty about dermatology. Just one thing that was not on this panel, although I think everything that almost every speaker said, in my family, our big problem is Alzheimer's at a young age. And I think that I've been reading a lot of different things. There's a classmate of mine from college William Lee, who wrote a book, Eat to Beat Disease. I used to be kind of a more like, just everything is sort of direct. You can do this, like if you have a problem, you take a statin. If you need calcium, you take it. But I think that, as everyone has said, there's a lot more nuances. Exercise is important for not just cancer prevention, but also Alzheimer's prevention. What we eat, not just, I think as women, we're always concerned with what we shouldn't eat. Don't eat this, don't eat that, lose weight. But it's more than that. I think that eating foods that are almost like medicine can help anti-inflammatory state of your body, yes, which is important in every single one of the fields that we're discussing. So I hope in the future, there will be more of a simple conversation that we can have about Alzheimer's prevention, which is difficult because the neurologists, I think, are first sort of grasping a lot of the new data that's coming out there. It's certainly not up to the speed of like colorectal cancer management. But I think it's something that as women, we are very prone to, and the odds are a lot of us on this call will have it. So I think, again, just taking care of your overall health, not just being black and white, don't eat this, yes, eat that. Look at your body. If there's a problem, when you call the doctor's office, call every day and say, I really have this problem and I'm scared, not just that I'll take the next available in 6 months. Agreed completely with that.
Thank you. Thank you, Madeline. Meryl, final words.
Final words. Osteoporosis is a silent disease. A fracture is a serious consequence. We didn't get into this today, but we have very effective treatments to decrease fractures. And I think in terms of the overall importance of good nutrition, exercise, healthy lifestyle, sleep, those all apply to bones. And I'm just going to close with a statement that I had worked on with the Massachusetts Department of Public Health. Strong bones, strong body, strong minds. Thank you for asking me to participate in this program.
Thank you, Meryl. And Allison, closing words.
Yeah, so I think this is lovely how everything we've said is kind of built on what everyone else has said each session. So I like that. I just want to share some data from the American Heart Association Registry, because from 2010 onward, they really started collecting data on those patients that hit the markers: weight, exercise, blood sugar, blood pressure, and cholesterol. And not only did we see a decline in heart disease, we saw a decline in cognitive decline and also a decrease in cancers. So there really is tremendous overlap. So I think that healthy lifestyle approach, right, is really, worthy of all of our attention at whatever stage of life we're at. The other plug I'll just put in that we didn't talk about is really markers of inflammation. And I will say the same as that calcium score. If you have blood evidence of chronic inflammation, that really accelerates a lot of these processes. And that would be also something that you should really, have a specific conversation with your doctor about, as we're, talking about this picture of prevention of multiple chronic diseases. So it was lovely to be part of this today. Thank you, everybody, for participating and listening.
Perfect. Thank you. And thank you all. I'm going to hand it back to Nancy to close us off.
Thank you. Wow, what an incredible hour this has been. I want you all as my doctor, so that's number one. But really, a round of applause. You guys are fantastic. There's a million questions in the chat, so I don't think this is going to be a one and done. We're going to have a part two. I just wanted to let everybody know that the next couple of weeks is the holidays, and everybody will be enjoying time with their family and friends. So happy holidays, and there won't be any presentations by the Boston Club, and we will get back in January. In January, we do have our Winterfest, which will be held on January 25th, and it will be in person. So we're excited about that. It'll be great to see everybody. And look for some other programs. We have another program coming up from the Corporate Board committee, and that I think is on January 20th. Ins and outs of private and public board service. And I think that's all I have for announcements for now. And thank you to Carolyn and the committee, the Healthcare Task Force, for pulling this all together. And I hope that we will continue to see you at future programs. So thanks,
Nancy,
everyone, and happy holidays.
Nancy, sorry,
Carolyn,
Nancy,
yeah.
I see some new faces, some folks who are not Boston Club members. So can they just reach out to info at the Boston Club if they want to inquire about membership?
Absolutely. Yep. info@thebostonclub.com. I did save, this is program is being recorded, and I did save all the chats. And I know there's a lot of questions. Maybe we can pick them up at future time. Okay, everyone, have a lovely, lovely holiday. Thanks for being here. Bye.
Thank you.